Steele, my lady. Dr. Atherton, just two more topics, if we may, both of which relate to ethical issues in clinical decision-making during the pandemic. And the first of those concerns a clinical prioritisation tool. Did you consider that if at some point in the pandemic demand exceeded critical care capacity, that clinicians would need a national decision-making tool with clear criteria to apply to ensure that those decisions were based on an agreed approach and consistent across Wales?
Yes, that was a material consideration for us. You'll remember back to the days, late February, early March, we were looking at what was happening in Italy and watching the difficulties that hospital systems were experiencing there. And there was a real visceral fear that we would get into that same position in the UK and in Wales. So there was some thinking about what would we do if we reached that point, and how would we make sure that people had access to services? How would we prioritise care for people if we reached that point where the system could no longer cope with the demands that were placed on it?
And did the Welsh Government, in fact, produce a decision-making tool to assist clinicians in the event that they needed to make those kind of prioritisation decisions?
No, it didn't. But the Welsh Intensive Care Society produced one. Just to go back a bit, there were discussions at the Four Nations, I think, through the senior clinicians group, about what we would do, and there was some work which was initiated by intensive care leads at UK level to develop a decision-making tool to help with that issue should it arise. So there was some work that happened at UK level.
I think that was in March 2020. Is that
quite likely? Quite likely. Quite likely.
And was that taken forward?
And in Wales, I think what happened was that the Welsh clinicians were engaged with that work, and they obviously knew that work was going on, and so the Welsh Intensive Care Society actually produced a document which it circulated to the system, which provided advice should we get into that position. It was trying to prepare the system for if we reached that unfortunate position where we couldn't meet the needs of the population.
I think that was the decision-making tool that was also produced with the Wales Critical Care and Trauma Network.
Exactly. Yes, it was. Yes.
Perhaps we can have a look at that document, please. It's INQ 3000 338460, and it's behind tab 46. I hope in your bundle,
okay.
Dr. Atherton, if we need to look at it. The Wales Critical Care and Trauma Network, is that an NHS Wales body? What's the status of that organisation?
Sorry, the Welsh?
The Welsh, we can see that it's badged here, NHS Wales Critical Care and Trauma Network.
Yes.
Is that part of
the trauma network?
One of the NHS bodies?
It's not a formal body in its own right, but it's a pulling together of critical care leads from across the different health boards to provide leadership. We have a number of networks in Wales. This would be one of them. Yes.
Thank you. And we can see that that's dated the 13th of April 2020. And if we can go to page 5 of that document, please. This is the tool itself, and we see that there are 4 numbered factors to take into account an assessment of critical care benefit and risk. Number 1 is age, with an arrow pointing from age below 50 to above 80. And then number 2, a clinical frailty scale going from very fit to terminally ill. And then number 3, a comorbidity box that lists a number of conditions with empty boxes next to them, tick boxes. And number 4, female and male with the arrow pointing towards male. And below that, critical care escalation, unless patient with capacity declines for full escalation where necessary, then may benefit from critical care admission, consider discussion, and then less likely to benefit from critical care admission. So we can see that the clinical frailty scale is included there, but not with a numerical scoring system. Is that right?
That's correct, yes.
I think by email of the 10th of April 2020, this tool was circulated to you. And at that time, I think it did include a numerical scoring system. Do you recall that?
I do recall it very well. And could I clarify as well? You know, I referred to the work that was done at UK level, which did come back to the senior clinicians group. And that did have a scoring system on it. And when it came back, we recognised that that was not appropriate, and so it was never agreed at a UK level. And I think the same discussion partly played out in Wales. I think you're right that there was a version which had a scoring system, and it was felt that that was an inappropriate thing to have on a document of this nature.
What was the problem with having, or perhaps I can put it another way, why was it appropriate to have this clinical frailty scale set out, but without the numbers? How did removing the numbers from this render it appropriate? Well,
the problem with the scoring system was it was viewed as being too medicalised. There were concerns which were expressed, because there was quite a wide consultation at UK level on the document, but quite late on there were concerns expressed, particularly by charities and bodies representing disabled people, that the CFS, the clinical frailty score by itself, could lead to you can't be too objective with it. It should be regarded as a subjective thing, and that the way that a treating clinician views a person's health and the value that person places on their health isn't necessarily the same value that a person would place on their health. So it became highly problematic, and on that basis we never approved at Four Nations level the use of a scoring system.
But if we could come back to this document.
Yeah, I'm about to. But so what this document, I think, very sensibly does, and you need to read it, of course, in its entirety, because I felt that this was an excellent communication from the lead clinicians here into the system. But they made it extremely clear that both the tool here, the Appendix 1, the tool, well, there it is in black and white at the top. The tool should not be used in isolation, must be read in conjunction with the narrative. And the narrative explains that individualized decision-making is absolutely what we need to achieve. So as a tool to assist in that process, I think this was a very useful thing, but on its own, and certainly with a scoring system, a numerical scoring system, it was seen as not appropriate.
There's still an arrow going from the bottom of the clinical frailty scale to the top of the clinical frailty scale. So a clinician's not taking into account exactly the same factors, just without a numerical scoring system.
Well, these are all things to think about. So the arrow also applies to the less than 50 to the over 50. All it's saying is that the risk of intensive care increases as you go up up the arrows, and the benefits decrease. That's all it's saying. So it's helping. It's intended to help clinicians decide who can best benefit from intensive care facilities, something that they have to decide on a daily basis, within or without the COVID issue.
Were you made aware during the pandemic of any incidents of individuals being denied escalation in their care simply due to their age in Wales?
Denied?
Escalation of care?
No.
Due to their age?
No, I wasn't. No.
Thank you. Was this tool in this final form without the numerical scoring system. Was this approved by the Welsh Government?
No.
Can we have a look, please, at your email about this? It's INQ 000484821. It's behind tab 37 in your bundle, please. And can we go, I think, to down to the next page? And this is where you say the approach is fine, it's the scoring system which is causing the anxiety at the moment. And then if we can go up to the first page, please. And this is your deputy, Chris Jones, saying, yes, agreed, very helpful suggestion. So this tool had been circulated to you or to the office of the Chief Medical Officer. And you've been asked for your input on this, and
yes.
You've given your input, and they have accorded with your suggestion of removing the numbers. So what did the Welsh Government do in relation to this tool? Was it circulated amongst what
Yeah, it was circulated
by
by the Welsh by the Welsh Intensive Care Society and the Trauma Network. So it was circulated to all the relevant clinicians.
And do you know whether that tool was used within local health boards to make decisions about prioritising patients for critical care?
I suspect it was helpful to clinicians, but I don't know that for sure. You'd have to ask them.
Can we come on, please, to the topic of do not attempt cardiopulmonary resuscitation, DNA CPR notices? I think there was throughout, prior to the pandemic, an all Wales DNA CPR policy for medical professionals, yes, called Sharing and Involving. I think the version in circulation at the beginning of the pandemic was version 3, published in 2017, and that was updated in 2020. Did the Office of the Chief Medical Officer have any involvement in formulating that DNA CPR policy for Wales?
Well, I didn't have any personal involvement. Now, Chris Jones may well have been involved and discussed it with the clinicians who led on it, because it was a clinically led document. And in as much as it became a Welsh policy, it would have been approved, ultimately by the minister, I guess.
Thank you. Now, in relation to issues around DNA CPR notices during the pandemic, on the 17th of April, you, together with the Chief Nursing Officer of Wales, issued a joint letter to all the local health boards. Can we get that up, please? It's INQ 000300106, and this is behind tab 41 in your bundle. If you want to look at the paper copy, Dr. Atherton.
Thank you. Yep.
If we can move down that page, please, on page 1. You've indicated that you had been made aware, recently we've been made aware of concerns from groups advocating for disabled and learning disability communities in Wales about how the clinical frailty scale could be used inappropriately in making decisions on escalation of care and do not attempt cardiopulmonary resuscitation for individuals being treated for COVID-19. Just pausing there, under the All Wales DNA CPR policy, would it be appropriate to take the clinical frailty scale into account when imposing a DNA CPR?
I'd have to read through the policy to see whether it's mentioned in there, but I think it would be appropriate for it to be one of the considerations which clinicians would use to determine about whether an attempt at cardiopulmonary resuscitation should be made.
Thank you. And if we can look at page 2, you identify that there have also been concerns raised by the Older People's Commissioner about care and treatment options that will be available to older people, some of whom have felt pressurised into signing DNA CPR forms. And you've gone on to say that you were not aware of any CPR decisions being made purely on the basis of an individual's age, disability, autism, mental illness or other condition. but nevertheless you felt it important to write out to the system to provide some measure of reassurance. Is that correct?
That is correct, yes.
And you go on to say, age, disability or long-term condition alone should never be a sole reason for issuing a DNA CPR order against an individual's wishes. Was that your understanding at the time, that it was necessary to have patient consent to a DNA CPR order?
Yes.
Thank you.
I need to clarify that. So if a patient has mental capacity, then it's clearly a duty on doctors to have that discussion with a patient before they make that decision. It becomes problematic where people don't have mental capacity, in which case the discussion would normally be had with the relatives
If I can tell you, but not to have a discussion, but to have consent.
Yes. Yeah,
Did you consider it was necessary to obtain a patient's consent to a DNA CPR order, or did you think that that was a clinical decision for a doctor that should be discussed but wasn't determined by
I think there can be. It would be very unusual to have a DNA CPR order without the patient's consent, but the patient can't always give consent, of course.
Thank you. And you go on to say, it remains essential that decisions are made on an individual and consultative basis with people. It is unacceptable for advanced care plans, with or without a DNA CPR form completion, to be applied to groups of any people of any description. These decisions must continue to be made on an individual basis according to need and individual wishes. What was it about advanced care plans that was objectionable in your view?
It wasn't advanced care plans which are objectionable. I think advanced care plans are excellent if used appropriately, and we have a whole process in Wales of developing advanced care plans.
Can I take you to the wording, please, of the letter that you sent out? It is
Yes.
unacceptable for advanced care plans, with or without DNA CPR form completion, to be applied to groups of people of any description. Do you think that the message there was potentially a little confusing, that there was something unacceptable about advanced care planning?
No, I don't agree with that at all. I think it's clearly saying that advanced care plannings cannot be applied to groups of people. They should be applied to an individual, not to a group of people. I think that's absolutely clear in the text.
What did you understand by advanced care planning?
Advanced care planning is the discussion that you have with an individual, or on occasions with the relatives of an individual, or sometimes with both, about what their future wishes will be. So it may include discussion around DNA CPR. It doesn't have to include a discussion around that at all. It may include a discussion about their advanced wishes, if they become ill or if their condition was to deteriorate. So it covers a whole range of things, and there's a comprehensive suite of documents which is produced by, we have in Wales an advanced planning strategic group, again led by clinicians, that develop and update all of these documents and tools.
Thank you. In this letter that you've sent on the 17th of April, I think there's a link, I think further down the letter. Forgive me, it's on page 1, I think. To the statement of the COVID-19 moral and ethical guidance in Wales. You don't appear to have signposted in that letter to the existing All Wales DNA CPR policy. Do you consider that that was an oversight?
Well, I think that that would have been quite widely circulated, not by Welsh Government, as we just discussed, but by the clinical network. And I think it was more targeted towards the leaders of the intensive care systems, really. I'm sure medical directors would have seen it.
If we can scroll up, please, we can see who that letter was actually addressed to.
Indeed.
And it was addressed to the Health Board chief executives, the medical directors, directors of nursing, and directors of therapies and healthcare scientists. So this was going out to the local health boards. Do you think it would have been helpful for those recipients of the letter to have been signposted to the existing detailed DNA CPR policy?
It may have been. It may have helped.
Thank
yes,
you.
Yes.
You wrote again to the system with the Chief Nursing Officer on the 10th of March 2021. This time you were writing following media reports, I think, of inappropriate DNA CPR notices in England in relation to people with disabilities or learning disabilities specifically. Were you aware at that point of any similar issues in Wales?
There had been a couple of instances where it had been brought to our attention that there may be problems with that issue. I think one was out in West Wales, and there was a practice somewhere, I think in one of our health board areas, where it was reported that there had been inappropriate either group or issuing of DNA CPR without proper consideration or discussion with the patients, as we were just discussing. So that's what triggered the second letter, as I recall. It was a reminder. Now, none of those experiences, as far as I could see, were ever kind of clear. I mean, obviously, it was a very difficult time, and people were anxious about decisions being made about themselves, about their loved ones. But I don't. What we made very clear to the system, again through medical directors, and when we discussed this at medical directors meetings, was that when a DNA CPR process was felt not to have been followed, if a patient or a relative complained about that it should be properly investigated by the health board. And as far as I'm aware, that did happen.
I think, in fact, you wrote out to the system for a third time in April 2022, and on that occasion there was reference made to a specific incident that had taken place in relation to a patient with a learning disability who had had a DNA CPR notice issued solely on the basis of that learning disability. And I think, again, in the letters of the March 2021 and April 2022, there was no link or reference to the All Wales DNA CPR policy for clinicians. Do you know why that wasn't linked in those letters or referred to in those letters?
No, I don't know. I don't know why that was.
Having been made aware then of both media reports and some specific incidents in Wales in relation to inappropriate DNA CPR notices, did your office or any other Welsh Government body, to your knowledge, either investigate or commission an investigation into whether there had been a widespread issue with inappropriate DNA CPRs in Wales?
I don't recall commissioning anything or Welsh Government commissioning anything, but the implication that these were widespread was not something that certainly I felt, or Jean White or Sue Tranker subsequently felt was an issue. These were rare events which needed to be investigated by the health boards, and our view was that even one event was wrong and there should be absolutely not the practice, and that's why we consistently wrote out to the system.
Can you tell us how you came to the conclusion that these were not indicative of a widespread practice in the absence of any review or investigation?
Well, it's really not the Welsh Government responsibility to or ability to monitor the number of DNA CPRs or whether they're appropriate or not. That's really a job for the health board. So when all this was coming up repeatedly, we had discussions with medical directors who were responsible for overseeing within their health boards how the DNA CPR policies were being implemented.
And did you ask the local health boards to undertake that sort of review?
I didn't know, no.
Did you ascertain whether the local health boards had policies that were in accordance with the All Wales DNA CPR policy?
Well, there was an expectation that they would have that. I mean, that was clear in the DNA CPR policy that individual health boards should be having their own policies and monitoring their policies. It's the health boards to monitor the policies and the implementation, not the Welsh Government.
So those 3 letters to the system did not refer to the All Wales DNA CPR policy. Were any steps taken during or after the pandemic to ensure that clinicians in Wales were familiar with and fully understood the All Wales DNA CPR policy, sharing and involving?
Well, the policy is updated every 2 years. I think it was updated again in 2022. Whenever it's updated, it goes to medical directors. I talked already about the advanced care planning policy and processes and the tools that are contained within there. So tools are widely available to staff, and health boards include them in their staff training. So I am reassured that the system does have that training, and the monitoring function through the health boards, yes.
Are you aware of the, turning to advanced care planning specifically rather than DNA CPR notices, are you aware of the respect forms that are used in many regions of England and indeed in Scotland to record patient wishes and views in terms of advanced care planning? And are there any reasons why the respect form could not be adopted in Wales?
Can I just backtrack slightly? To correct something which I previously said. I think Healthcare Inspectorate Wales undertook an audit of DNA CPR policies in Wales in 2024.
In 2024.
And I think it's quite important we kind of look at that, because HIW is the body which sits, if you like, above the health boards and monitors their compliance with some of the policies that came out. So there is a piece of work around that.
So as far as you're aware, there was an audit of policies, but not an audit or review of individual DNA CPR?
No, that would be done by the health boards. The audit of the policy would and how it was being adhered to and by the health boards would be done by HIW. Yeah.
But you're not aware whether the health boards did undertake any such review?
Well, I wouldn't know that, but the HIW report may well refer to that, because it should look at that.
Thank you.
I'm sorry to go back to your question, maybe. Yeah.
The question was, is there any reason why the policy of respect used in parts of England should be used in Wales as well?
So as I say, we do have an advanced care policy. That's updated regularly. It's not owned by the Welsh Government. It's a network issue, again. As I understand it, the clinical leads of that do look, whenever the policy is updated, at the respect process. There are some concerns in Wales from some groups that it's perhaps not doesn't meet all of the needs in Wales. I think the principles of the respect process are incorporated within our advanced care planning, but the tool itself, elements are taken from it, but I don't think there's a desire to whole scale just to adopt that policy. We have our own policies in Wales, which we believe are robust and actually, in some ways, more comprehensive, because it's not just a policy, it's a suite of tools which people can use.
Thank you. Moving on now to your views of the lessons learned from the healthcare system response to the COVID pandemic. What do you consider to be the most important lesson that can be learned from the response of the clinical healthcare system in Wales? And do you have any recommendations building on that for future pandemics?
I don't want to just reiterate some things that others said. I'm sure you've heard this before, but the big lesson to me was that the system didn't have enough capacity to be able to respond in the way that we needed it to. And in a way, that's because we've tried to make our NHS, and it's true in Wales as in the rest of the UK, as efficient as possible. And in some ways, efficiency is the enemy of preparedness, because we don't have the sufficient expansion capacity. So the big lesson for me is thinking about how we can expand capacity. In intensive care, as we've been discussing, we did expand intensive care capacity from 152 beds to more than 300. We more than doubled, but there weren't the staff trained to be able to move into those positions. So thinking about how much spare capacity for all sorts of things, we've talked about intensive care, but for all sorts of things, is really important going forwards. The second thing is the flexibility of the workforce, the ability to move the workforce. We did a fantastic job, but to move them and to make sure they have multi professional skills that can move between roles when needed. I mean, that's my first recommendation. The second one really is more about the basic health of people in Wales. And this is a big ask, but the health of people in Wales is not as good as it needs to be. We didn't start from the right place, and so when we talked about those inequalities, we talked about the differential impact on people. But if those inequalities were smaller, if the health of the basic health of the population was better, we would have fared better than we subsequently did. Those I think are the main areas that I think some of our communications, could have been better, but that's an internal matter, and we can think about that. Some of the connections. Do you remember we talked about the connection on policy level between Welsh Government and the devolved nations, let's say, and the UK Government? Strengthening those would be really important as well. Those are the kind of main things which come to my mind.
Thank you very much, Dr. Atherton. I have no more questions for you.
Thank you, Ms. Steele. Ms. Vera Ratner. Can you see? She's that away.
I see her. Thank you.
Good afternoon. Dr. Atherton, I ask questions on behalf of the Welsh COVID Bereaved Families for Justice group, whose members, many of whose members lost loved ones through nosocomial infection. And I have a number of questions for you on their behalf today. The first is this. Today you were asked about the EMG report of the 4th of June 2020, which said that there was weak evidence of transmission, and you were asked about the application of the precautionary principle. In fact, the EMG report states that the evidence of aerosol is weak, but there is significant uncertainty around the relative contribution of all transmission routes. The approach to risk should be based on the well-established hierarchy of controls. So the Welsh bereaved are concerned that when asked about the precautionary principle, witnesses tend to revert to masks and suggest that application of the principle would, as you suggested today, result in everyone wearing respiratory hoods. Do you think that when considering the precautionary principle, the focus is in fact too much on such outcomes like masks than on the risks arising from the science?
Well, forgive me, it's a rather theoretical question. I'll try and answer it. I do think at the stage we were at in the pandemic, even in June 2020, the risks, the modes of transmission were all becoming clearer. They weren't entirely clear. I think I've already mentioned that the precautionary principle, I don't just apply it to masks, I don't think. I do apply it to the whole process of healthcare, but it's only one tool in the box. It's not the only or the one that supersedes all others. I do think we have to balance evidence very carefully, and that's why we created the scientific architecture, including the EMG that you mentioned, feeding into nerve tag, feeding through into the IPC cell. And I do think that the precautionary principle can mislead us sometimes because it can be argued both ways. It can be argued as a reason to do things and as a reason not to do things.
I think that reflects your earlier answer, but may I ask just this? What was the downside, in your estimation, of assuming that long-range aerosol transmission was taking place when the evidence for it was weak?
Well, I don't think we did assume that it wasn't taking place. As I say, there's a continuum of droplets to small particles to tiny particles. I think that was understood really from quite early on. So I don't really think that. Sorry, ask your question again, please. Can you?
What was the downside?
The
You
downside.
talked about the downsides of
Yeah.
assuming that long-range transmission was taking place when the evidence was weak.
So there was an acceptance that particles of all sizes. The empirical evidence was that the closer you were to somebody who was infected, the greater the risk. That came about very early and didn't really change. So there was a good reasons to take the action that the IPC cell did take. Yeah.
Thank you. I'm going to ask you my next question. We also heard your evidence this morning that there was an anxiety around the levels of PPE stock that you were holding. At paragraph 174 of your witness statement, you say that you do not recall any specific concerns on shortages of PPE or poorly fitting PPE that was notified to you directly. Now, on the 4th of June, Vaughan Gething told the Senedd Health, Social Care and Sport Committee that Wales came within days of supplies of some items rather than weeks. So in the light of all of that, do you agree that there were issues with the supply of PPE at the early stages of the pandemic in Wales?
So thank you. Very early in the pandemic, there were real concerns, visceral concerns that we were going to run out of PPE. The stocks were running down very, very quickly. I think what I say in my statement is that I was never informed that we actually ran out of stocks. I believe that to be true. We never, in Wales, ran out of stocks. I think we came very close, but we continued to keep the pipeline of stocks moving into health and into social care. To keep those pipelines moving. Now, what I can't say is that there weren't local distribution issues, because obviously the local health boards had to receive stock and distribute them within their both the healthcare facilities, primary care, and subsequently into social care as well. So there may well have been local distribution, but we never ran out of PPE.
Thank you.
Yeah.
Thank you. I'm just going to remind you that it says do not recall any specific concerns on shortages, not running out. But I'm going to move on to my next question, which is on supply again. Concerns are raised in an email trail. I'm going to ask, please, if we could have INQ 000383997, page 1, up on the screen, if I may. It's an email trail dated the 27th of March. And it's the first page to the bottom of the first page that I want to ask you about, Dr. Atherton. It's sent by clinicians from health boards in Wales and ultimately brought to your attention at the top of the page where it says, "Hi, Frank." Do you see that?
Yeah, I do. Do you have a tab number, please? I find it
It should be
difficult
tab
to read these things
57,
on
I
the screen.
apologise.
Tab.
57.
Thank you.
I'm looking at the screen because there are some redactions on the version there which were not in the version that I downloaded last week, but I see your name is there. So perhaps you could look at that copy.
Yeah,
so you were sent an email saying that there is a situation in Swansea, contrary to a discussion about unified PPE approaches across Wales, following Public Health England advice. That's the top email, you see that. And it forwards to you the email below from Esther Yude. And that says she entirely agrees with comments regarding the need to unify Royal College guidance with PHE guidance on infection control. Do you see that? And it's the second paragraph there, or the third paragraph that I'm interested in, where it says, Frank, and that's correct, it says Frank, doesn't it, made it clear that it is important that we all follow the PHE guidance so that high levels of PPE are not used unnecessarily, risking the supply chain at a later date. So my question is this: do you agree that decisions were being made as to what level of PPE should be used by healthcare workers to avoid running out of supplies rather than due to the risk presented to healthcare workers?
No, I don't agree with that. So this email chain, was sent to me actually by David Tuthill, who's a paediatrician working in Wales, very gifted paediatrician, and he was raising the issue of whether babies should be regarded as COVID positive.
Sorry, Dr. Ether, I'm really going to stop because I have limited time, but I just wanted to focus you onto the comment that was made by you, that you were concerned that that it was necessary to follow guidance so that high levels of PPE are not used.
So can I-
The context is not necessarily necessary at this point.
Yeah, understood. Thank you for that. Yeah, thank you. That's the reported accounts of my discussion that I had with the Academy of Medical Royal College of Wales. I met with the Academy on a regular basis throughout the pandemic, and all of the clinical leads, the college leads, would have been present at that meeting. So this is a reporting of what I'd said at that. And basically what I was saying at that meeting, from my recollection and from what I'm seeing in front of me, was that it's important that we follow the IPC guidelines. I'm not saying that the primary reason is because of a stop level. I don't believe that I felt that at all. I mean, it may well have been a concern, a subsidiary concern, but the main reason for following IPC guidance was because that was based on the best evidence that we in Wales and we in the UK had through NERVTAG and the IPC cell. So it wasn't a question of supply.
But you accept that is accurate in terms.
Well, I accept that that's what
so far
he
it
said.
goes.
I accept that's his interpretation of what I've said. But I would have had a 40-minute discussion with the Academy, and he may have taken one line from that.
Thank you. My next question is on asymptomatic testing. At the Sened's Health, Social Care and Sport Committee on the 18th of March, you said, and that's 2020, I just need to stress that there's very little point in testing anybody who is not symptomatic. The test will only be positive if someone actually has symptoms. So at this date, it's correct to say, isn't it, that you do not believe there was any point in testing asymptomatic healthcare workers?
Date of that again, please.
18th of March 2020.
So at that point in the pandemic, asymptomatic infection was starting to be recognised. Asymptomatic transmission was not regarded as a very significant mode of transmission. Now that changed over time, but in early March, when we were still learning about the virus, that statement would have been true.
Oh, thank you. The next point then is that testing of asymptomatic healthcare workers in England started from 30th of April 2020. And you further said to the BBC then that the Welsh Government was, in quotes, still trying to reach across to England.
I do apologise for interrupting. I think it's been necessary to stop the live feed.
Oh.
I think we can resume shortly.
Sorry?
I think we can resume shortly.
I confess I'm confused. If Mr. Smith would just come and let me know, or I can let you know. Sorry about it. Make sure it doesn't come off your time, Ms. Veeratna.
Yes, my minutes are ticking.
My lady, forgive me. I think it's necessary for your ladyship to request that the feed be stopped because a name has been mentioned in error.
No, I'm not going to stop it. Somebody can alter that later if it's been mentioned in error. We can go back over it and amend it. We're short of time this afternoon,
Very
so no.
I didn't mention. Okay.
Please carry on.
All right. I'm going to repeat that question. I'm sure that would help you. Dr. Atherton, my question was around testing of asymptomatic healthcare workers in England from the 30th of April 2020, and that you said to the BBC that the Welsh Government was, in quotes, still trying to reach across to England to understand the exact rationale for the changes that they've made in various categories. So the question is, why did you not recognise the value in asymptomatic testing at that time and at that date, 30th of April 2020?
Well, thank you. Look, I have to confess, I'm a little puzzled by the question because in March 2020 there was very little testing capacity available. So it certainly wasn't the case that England or anywhere was testing all healthcare workers who were asymptomatic. Asymptomatic testing came in much, much later, round about September, October, November 2020.
Well, I can reliably inform you that on the 30th of April, England started asymptomatic testing of healthcare workers.
Not of all healthcare workers.
Well, that is
They
my
couldn't have
question
done
to you.
because there just wasn't enough capacity.
My question is focused on the value of asymptomatic testing at that time Do you accept that or not?
Well, that time, in April 2020, as in March, there wasn't an understanding that asymptomatic transmission was a significant feature of the pattern of transmission of the disease.
Okay, thank you. So I'll move on to the next question, which is that at a senior clinicians group on the 4th of May, it's minuted that approximately 5% of staff are asymptomatic carriers, with up to 9% in one hospital. CF 0.64% in the community from an ONS study. And then it records, need to be really clear why we will not test all HCWs. So again, the question is, do you agree that by 4th of May 2020, it was untenable to maintain a stance that there was no value in regularly testing healthcare workers, regardless of symptoms?
Well, I think by the time we reached May, it was becoming increasingly clear, and this was, as I recall, this was quite a complex paper which Aidan Fowler, the Deputy Chief Medical Officer in England, one of the DCMOs in England, brought to the senior clinicians group. It was a very preliminary finding from the Vivaldi study, and it did concern me, I think it concerned all of us, that there was a relatively high prevalence of asymptomatic infection, not asymptomatic transmission, but asymptomatic infection among healthcare workers. The comment I think that I made at that time was, well, if that's the case, then we will need to move towards testing asymptomatic healthcare workers at some point. At that time, on the 4th of May, again, there was not sufficient capacity of PCR testing within the system to be able to undertake that.
I think you've answered
Subsequently,
my
it's when lateral flow devices became available, widely available, that became a feasible option. But it just shows, I think that line just shows that we were thinking in those terms about how we could bring in testing for asymptomatic healthcare workers.
Thank you. I want to move to another topic, which is about introduction of routine testing. Now, you've already been asked about the delays by the Welsh Government in announcing routine testing of healthcare workers in December 2020. But I want to ask you about the incremental testing of healthcare workers, which was due to be rolled out after that time, with full rollout due to be January 2021. Do you agree that the regime was not in fact rolled out until mid-March 2021 and often as late as July 2021 in some cases?
I think it was rolled out earlier than that as a national policy. Again, my colleague...
Yes, so the policy was in December 2020, and I'm asking you, do you know and do you accept that it wasn't actually rolled out until mid-March and July 2021? Just answer that,
if you let me finish my answer. I know that the supplies of the lateral flow devices came into Wales were distributed in December, fairly quickly after the policy was agreed through our TTP programme. They went out to all the health boards. I think there was a variance in the speed with which the health boards were able to implement the testing. So in terms of full rollout, I suspect you're right that some health boards didn't quite get there as quickly as we would have expected. I think there are two other things you need to think about when you look at that. One is what else health boards were doing, and if you remember, this was exactly the time, Milady, that vaccines were being brought in, and so there was a huge impetus on getting vaccines into people. And the other thing I would also flag is that although there was a delay, I think health boards could have been quicker, I'll accept that. I don't think the situation was much different in England, which is obviously a much bigger system anyway. So I think those comparisons are perhaps not entirely.
Okay, I'm grateful. I'm moving on to another question. In the expert report by Doctors Shin, Professor Gould and Dr. Warne, they say that hospital onset cases during the first wave represented 5.3% of all laboratory-confirmed COVID-19 cases in England, 6.4% of cases in Scotland, and 10.5% of all laboratory-confirmed cases in Wales. Question is, why were the rates of hospital-acquired COVID-19 as a percentage of all cases so much higher in Wales?
I think if you read down that report, you'll see that the professors also point out that that not too much should be read into that because of the differences in counting, the differences in testing, the differences in hospital admissions. So they put enormous caveats around that data. So it's not data that I recognise. The reality is that there were high rates. There were high rates in all the countries. I don't accept just on the face of it the differences in the statistics.
Thank you. I just wanted to ask you about the COVID pathway. There's a letter that we have dated the 9th of April 2020 to all CEOs, the Chief Operating Officer and Medical Directors of Welsh health boards and trusts, in which you discuss the All Wales Hospital COVID-19 pathway. But it appears that a copy of this document no longer exists. So the question is, can you assist the inquiry why that is, and why there's no copy retained in order to ensure accountability and compliance with that pathway?
Yes, I can. So the pathway was a very innovative piece of work developed by one of our esteemed respiratory consultants, who I won't name, who was a consultant in West Wales, and he led the respiratory health implementation group and was very effective, I think, early in the pandemic in assembling the evidence on what works and putting that into a toolkit, which was available, including the pathway that you rightly described. That pathway was then distributed through a private company, and the reason it's not available now, I think, is because it was in the domain of the private company rather than owned by Welsh Government.
I think we're going to have to leave it there.
And that was my final question.
Okay,
Thank you very much.
Thank you very much. Very grateful. Sorry about the interruption. Right, Ms Hannett.
Dr Atherton, I appear on behalf of the long COVID groups. My lady, in light of the evidence that was given this morning, we do not need to ask all the questions that we've been given permission for, so I anticipate I'll be a little less than the time that's been allocated. Dr Atherton, I have questions first about your role in advising on long COVID. You gave evidence this morning that you were not involved in advice on the identification or characterisation of long COVID. And you agreed that Dr Chris Jones was a member of the Welsh long COVID subgroup. You stated that you couldn't recall being provided with a briefing by Dr Jones on the matters discussed at that subgroup. Did you ever ask Dr Jones to provide you with a briefing?
I don't remember asking him. As I think I said earlier, I think most of my information flowed through, probably from Chris or from that group rather than Chris, through into the technical advisory cell and to me in that direction.
And did you personally ever provide any advice to the Welsh Government on the identification or characterisation of long COVID?
I don't believe I did. I'm not an expert in that field.
You describe your role as Medical Director of the NHS at paragraph 32 of your statement as a coordination role through the sharing of common issues and best practice amongst medical directors. And you say at paragraph 92 that your office would meet with NHS Wales medical directors, directors of public health, to ensure learning and consistency across the health and social care sector. Did you ever use those meetings to discuss long COVID?
I honestly don't know. We'd have to trawl back through the minutes of those meetings. I would be surprised if we hadn't, or if it hadn't come up in some form, whether as a specific item or as any other business or as something which was raised by members. I think it would have been discussed, but I can't tell you whether it was.
Does that mean you can't recall yourself personally providing advice on long COVID to that meeting?
Yes.
Similarly, many long COVID patients reported that they weren't believed when they sought care and support from clinicians, or that clinicians didn't know how to support them. Did you take any specific steps in your role as medical director to ensure that there was awareness of diagnosis and care for long COVID sufferers?
Me personally, no, but I think that the communication, it was understandable in the early days of the pandemic that primary care particularly, but doctors generally wouldn't have known really how to handle these kinds of questions. I think as the evidence became assembled, that there was more communication, I believe, from the group, but not from me personally, no.
Not from you. Can I just turn and ask you about long COVID services? NICE guidance published in December 2020 recommended specific long COVID clinics. Similarly, the Welsh Technical Advisory Group on Long COVID of February 2021 recommended integrated multidisciplinary care pathways for long COVID. Wales has not developed specific long COVID clinics. Did you provide any advice to the Welsh Government or to the health boards after either the NICE guidelines or the Welsh Technical Advisory Group on what services should be provided for long COVID in Wales?
Me personally, no, but I am aware, of course, that the group we just discussed has been providing that advice, and that systems have been set up to support people with long COVID in Wales. We've taken a different approach. It is true, we have a much more community-based approach. One of the main reasons for that is that we're trying to shift many of our services into the community. There are specialists who are active in the field of long COVID. I think we're still learning a huge amount about long COVID. The vast majority of the people with long COVID, I think, should be treated and treatable within the community. Those few who cannot should have access to specialist care. We need to make sure that happens in Wales. It does happen to a degree, probably need to expand it more, but that's the approach we've taken in Wales.
Thank you, Dr. Atherton. Have you personally taken any steps at all in relation to long COVID? You personally?
No.
And can I ask if that's because long COVID wasn't a priority for the Office of the Chief Medical Officer?
Well, it wasn't early on, and latterly that function has been discharged through my deputy, who has much more of an interest and much more of a expertise in that area.
Can I just ask you about that? Because your evidence doesn't set out any steps taken by Dr. Jones, and Dr. Jones's own witness statement doesn't give any account of what steps he has taken into respect of long COVID. So the inquiry isn't actually in a position to understand what steps the Office of the Chief Medical Officer has taken in respect of long COVID in Wales.
So the group that's looking at that, I think we established that Chris is probably a member. I don't think we established that he certainly is, but I think we established he's probably a member of it. But there's a whole group working on that important issue, and they have produced recommendations. They've led to the development of services, the Adferiad service in Wales, which is our community-based multidisciplinary service. So service development is going on. Whether it needs the Chief Medical Officer involved in that, when I'm not a specialist in that area, is a moot point. But there are clinicians closely involved in it with strong interest and strong professional background. I think it's also important to flag that we need to support people with long COVID. Absolutely we do. But there are a range of other people who suffer from various post-viral syndromes, and we need to make sure we don't forget about those as well. And I think that's been at the forefront of thinking as we've developed the Adferiad service in Wales.
Can I just ask you this, Dr. Atherton, finally? Given that the Welsh Government has estimated that there are some 96,000 people with long COVID, and given that can be a condition which is both long-term and disabling, do you agree that should be a public health priority in Wales?
I think it should be a priority and has to be looked at in terms of all the other difficult issues which health boards are responsible for. At the end of the day, it's the responsibility of health boards to develop those services, to understand the needs of their population, and to make sure that the services they provide meet those needs.
Thank you. Thank you, Melody.
Thank you, Ms Hunt. Ms Waddup. Oh, over there.
Thank you, Melody. I ask questions on behalf
No, I don't think you're switched on.
Turn it off. Can you hear me now?
Yep.
Perfect, thank you. Dr. Atherton, I ask questions on behalf of clinically vulnerable families. And I'd like to ask you first, please, about communication. The CMO's technical report acknowledges the importance of communication in relation to clinical vulnerability, and in particular, the need for communications to be clear about who was vulnerable, what was being asked of them in the guidance, and why, as well as the reasons for changes in that guidance. Do you think that communications in Wales to the clinically vulnerable and clinically extremely vulnerable in relation to those issues were sufficiently clear, prompt and regular?
Well, I certainly hope they were. We tried very hard to fill all those criteria that you just rightly described, because communication with this group was really important. As we discussed earlier, we were asking them to do something really very, very difficult. In Wales, we had a team working on this. We didn't just produce formulaic letters, or we tried not to. We tried to personalise it. We tried to make easy read versions available wherever possible. So, for example, we talked about people with Down syndrome. We produced an easy read, which I think was a really good model of good communication. And of course, we tried very hard to do everything. We did everything in Welsh as well as English, so we had that additional thing that we absolutely needed to do. Could we have done better? Of course, we could do better. We always need to learn how to do better. Our communications needs to be better. It was not easy. As I think I've said, I've spoken to some people in that group. I'm sure you've spoken to many more who were kind of grateful for the way we communicated. I'm sure there are plenty who felt that communication let them down and should have been better, and we need to learn from that. Thank you.
Thank you. That actually leads me to my next question, which is about understanding the impacts of the shielding programme. We know that in Northern Ireland, a survey of those shielding was carried out, which identified, amongst other things, a number of adverse social and psychological impacts associated with shielding. And we've heard in evidence from your colleague, Professor McBride, that the results of that survey, published in July 2020, were used to inform his advice after that, for example, in relation to the pausing of shielding, formulation of communications, etc. We understand that in Wales there weren't any specific surveys of those shielding about the impacts on them whilst the programme was in place. And my question is, should there have been?
Well, I didn't know actually about the Northern Ireland approach until I heard it, as you did, from Professor Sir Michael McBride. And I think it was an excellent piece of work that they did there. I don't remember it being discussed at the time. I think I agree with you. It would have been useful had we had the time and the resource to be able to do that. We would have learnt much more. So the answer to your question is yes.
Thank you. And then finally, I have a question relating to measures taken to protect clinically extremely vulnerable and clinically vulnerable patients while they were accessing healthcare. In your evidence this morning, you described the very close consideration being given to providing surgical masks to clinically extremely vulnerable patients when they were coming to hospital in order to support them. Was consideration given to providing clinically extremely vulnerable and clinically vulnerable patients with higher grade, better fitting masks like FFP2 or FFP3 masks? And if not, why not?
No. Well, I'm not saying that it wasn't considered. I'm saying it wasn't a policy. I think the view is and was that surgical masks provided good protection in largely non-clinical spaces, or the clinical spaces that those clinically extremely vulnerable or clinically vulnerable people would have been moving into. That was the basic provision, of course, for healthcare workers as well at the time. I think that had there been a suggestion, I don't remember anybody ever suggesting FFP3 masks. I think that would have been extraordinarily difficult given the issues around fitting and fit testing, etc. FFP2 masks were not widely used in Wales or in the UK generally, interestingly, which is a complete contradistinction from the rest of Europe, but they weren't a factor in thinking. So it was felt that the best protection for those groups was through the provision of surgical face masks.
Thank you, Dr. Atherton. My lady, those are all my questions.
Thank you very much indeed. Mr. Thomas. Mr. Thomas is sitting behind you, so please could you make sure that when you answer his questions you turn back, but by all means look at Mr. Thomas while he's asking the question.
Good afternoon, Dr. Atherton. Thank you, my lady. My lady, just so you don't become confused, I'm taking my questions 3 and 4 out of order. I'm doing them first.
Thank you.
Dr. Atherton, I'm representing the Federation of Ethnic Minority Healthcare Organisations, FEMHO, who advocate on behalf of healthcare workers from the Black, Asian and minority ethnic communities who are disproportionately affected by the pandemic. Okay. When did you first become aware that there was an issue of disproportionate infection and death rates amongst Black, Asian and minority ethnic healthcare workers and patients?
Thank you, Mr. Thomas. I can't pin a date on that, but I think the early data coming out of the first few hundred studies which were commissioned in the UK. That's looking at the demographics and the outcomes and the treatments provided to the first hundreds of patients that come through the system with COVID. I think that started quite early on to shine a light on the fact that there was a disparity which you describe in terms of, first of all, infection and subsequently the mortality issue. So if you were to ask me, if you tried to pin me down on dates, I would say April into May probably, but that's when we were starting to see significant numbers of patients.
Let me just ask you just a very quick follow-up on that. So when you became aware, April into May, what immediate steps were taken to mitigate this risk?
So at that point, it was still about gathering information. It wasn't entirely clear what was happening. The process in Wales was to make sure that we tried to understand it better. It was really about understanding. And really quite early on, because our First Minister and the Minister for Health took a very strong and active interest in this and established the Council of Inquiry, which Judge Ray Singh chaired. So there was a specific group set up to look at the broad issue of how people from the communities you describe were faring, and then a specific subgroup which was to look at the risks that healthcare workers specifically were facing and to come up with recommendations about how they could be better protected.
Right, so the answer to my question, if I've just followed your answer, apart from looking at the data, there were no immediate steps taken.
So there were two steps taken, the ones I've just described, which was to set up a group to look at the issue broadly in terms of the impact of COVID and specifically around healthcare and the impact on healthcare workers. So I think there's a fairly specific...
My lady, question 4 has just been answered, so I'm going to come back to questions 1 and 2. In your statement at paragraph 267, you mentioned that COVID-19 exacerbated existing inequalities, and in paragraph 273, you discuss how reducing these inequalities became a central ambition to shift towards prevention. Question, could you please identify what, if anything, has been done to reduce these inequalities, as you suggested?
Do you mean during the pandemic or subsequently?
Well, let's start with the pandemic and then let's turn to subsequently.
So, during the pandemic, I think I've highlighted a few actually earlier in my statement. I can go over them again if you like, but it was specific to different groups who were being disproportionately affected. I mentioned taxi drivers. I mentioned the risk assessment tool for healthcare workers. I think I mentioned the migrant workers particularly from Eastern European countries who were working in quite difficult circumstances in some of our food processing plants. So there were some very specific things during COVID. If you want to ask about how we're addressing inequalities more widely in Wales, this predates the pandemic, but it's ongoing work. There's quite a lot that we're trying to do. We recognise that focusing on the early years and getting the early years right is really important. We've had a process of looking at adverse child events in Wales, which has led to a better understanding of how we can support children and young people, support for free school meals, support for people coming out of the care system, because they often get left behind and when they emerge from the care system really struggle, and so additional financial support for them. There are a number of things like that. And then in broad terms, and I realise this is kind of broad policy, we work very closely with the World Health Organization to try to better understand our inequalities. We have a process called the WESRI. It's a horrible acronym. It's about looking at equity. It's a tool that we have developed jointly with the World Health Organization to try to understand our situation much better.
Thank you. Second question. In the report titled Coronavirus and the Health Inequalities, at paragraphs 4 and 19, structural inequalities and additional effects of racism are identified as additional contributors to worsen COVID-19 outcomes. Question, Was anything done to address these findings, and was there any monitoring that was carried out?
So this was a real eye-opener, I think, for all of us, and it came out of Judge Ray Singh's work, as I described, the kind of broader context of COVID rather than the specificity around the healthcare workers. Yeah, I mean, I think that has fed into our whole process of thinking about race and race equity in Wales. We have a very elaborate race equity scheme. It's never perfect. We need to do further work on that. All of our departments in Welsh Government and across the NHS are focused on race equity issues. There's far more that we need to do, but in process terms, that's where we are, I think. Yeah.
Were policies or actions implemented to address the disparities identified and to minimise preventable harm? And if so, in your view, were these actions timely and effective?
Well, in terms of the policy and practices, I think the thing that I'm most impressed by was the work that our colleagues in BAPIA, who I mentioned earlier, did undertake as part of that broader race equity work. They looked very carefully at the risks that healthcare workers were facing, and they developed a risk measurement tool which was disseminated across the health boards, was used very widely in the health boards, and actually was then picked up across the other 4 nations of the UK. So it's the one thing I would kind of point to. I'm sure there are others, but there were practical implications which were coming out of those work.
Yeah, I've got one more question, but just
Yes.
a tiny cheeky little follow-up to the answer you've just given. What you say that that's one thing that you feel has been successful. How was the success measured?
By its uptake across the healthcare system in Wales and beyond.
Okay. Final question. With the benefit of your first-hand experience and engagement with healthcare workers, what do you think can and ought to be done to reduce inequalities for ethnic minority healthcare workers to ensure that they don't suffer such a disparate impact in the event of a future pandemic?
Well, I would probably broaden that beyond healthcare workers, but certainly within healthcare workers, there are questions about parity of esteem, about promotion, about access to training, to learning opportunities. All of these are things which we're determined to get better in Wales at both monitoring and influencing.
Would you also agree allowing them to have a seat at the table where decisions are being made?
I think that's what I mean when I talk about promotion and getting more people into senior positions.
Yes.
Many of our if I think about the medical profession, many of our doctors in Wales, Mr. Thomas, many of them are working in SAS positions. That's sub-consultant posts, my lady. And so their terms and conditions are not as good as consultants. And I think there's more that we can do, and we are doing actually, to try to ease the pathway for them into consultant posts. That's kind of one example. The other bit of your question, broader, and it's more societal, is we do need to look at access to resources when we have something like a pandemic. People's access to statutory sick pay was limited sometimes according to their socioeconomic status and their race, their origins. And I think more consideration needs to be given to how we support people in those groups to do things like self-isolating, which was much more difficult for people in those groups.
Thank you, Dr. Atherton. Thank you, my lady.
Thank you, Mr. Thomas. Mr. Simblett, again, behind you to your right.
Oh.
Dr. Atherton.
Good afternoon, Dr. Atherton. I'm asking questions on behalf of the COVID Airborne Transmission Alliance, or CATA. You've supplied 2 detailed statements and given evidence in the course of the day. What's not in those statements is what you thought about the classification and declassification of COVID-19 as an airborne, high-consequence infectious disease. And I want to ask you about that, please. In January 2020, COVID-19 had been designated an airborne HCID, and you understood the rationale for that, did you?
Yes, I did.
And what I want to move to is that designation having been made, did you support actively the declassification decision in March 2020?
Yes. I'll expand.
Yes, please do.
So it was inevitable that with a new disease like COVID-19, not knowing anything or very much at all, nothing about the pandemic in January 2020, when it first became likely that we would start to see it in the UK, any new disease like that would be treated as an HCID. A high consequence infectious disease. And the reason for that, of course, is that we don't know enough about it. We don't know how infectious it is. We don't know how it would affect healthcare workers. We'd had experience with MERS-CoV, not in the UK, but in other parts of the world where healthcare workers had been very severely and adversely affected. So it was right to treat it as an HCID in the first instance. Once we started to see cases in the UK, that, first of all, no longer became tenable, and secondly, no longer became desirable. And it wasn't tenable because the HCID units only have a certain amount of capacity, and it wasn't necessary because we were learning more about how we could treat that, and it could be treated as a routine infection, like, I shouldn't say routine, but as a normal, perhaps, infectious disease, as we would treat any other respiratory disease.
Well, thank you. Of course, it was also an airborne HCID, and that moves me to my next question. Were there any discussions about the declassification decision being connected to problems with the supply, or as you said earlier, distribution or suitability of PPE or RPE?
No, the decision to move from being an HCID to not being an HCID anymore had nothing to do with the availability of any particular form of PPE. No.
All right. Well, thank you very much for your answers. Thank you.
Thank you, Mr. Simblett. Ms. Jones, Jessica Jones, get the right one.
Thank you, my lady. Dr. Atherton, I ask questions on behalf of Care Rights UK, John's Campaign and the Patients Association, all of whom represent people drawing on health and social care and their loved ones. In terms of what was known and when, your evidence in your witness statements is that from the earlier stage of the pandemic, it was known that age was a significant risk factor for severe illness and fatality from COVID-19, and that this was known from at least the beginning of March 2020. Is that correct?
Yes, I would agree with that, yes.
And at the same time, also in February and March 2020, the understanding in respect of routes of transmission was that the extent of asymptomatic and pre-symptomatic transmission was not yet known, but that they could not be ruled out. Correct?
Yes.
In this context, do you agree that the decision then to discharge patients from hospital without testing them increased transmission and mortality from COVID-19?
I fail to see the connection between the two previous statements. But to your question about whether in March, April, discharge policies should have included testing on discharge, no, there was no testing. There was very, very little testing. It would have been practically impossible to achieve that. I mean, at that point in the pandemic, we were just starting to learn about the virus. We were starting to develop testing modalities, the PCR testing, which then came on stream, first of all in the UK, and then we did develop testing relatively quickly in Wales, but getting to the volume that would have been required, that was much, much later.
Well, Dr. Atherton, perhaps I can ask this, which might help with the connection. Where you know that there is a vulnerable group, namely older people, and where you cannot rule out that there is asymptomatic and pre-symptomatic transmission, do you agree that a precautionary approach should have been taken in light of that evidence, so that, using the terminology that you used earlier, in the balance of benefits and harms, the risk of harm caused by the decision to discharge without testing outweighed any benefit?
Well, leaving aside the supply issue and the fact that it wouldn't have been feasible, I mean, there's a lot of thinking going on really in the early days of the pandemic, it was apparent that people in care homes were suffering. We started to see outbreaks, of course, in care homes. And the systems were put in place to try to limit that. The PPE was provided to care staff, discussions about spacing, about isolating people when they came back from hospitals. But it was much later that testing capacity became available, and it became an option to start to test people being discharged from hospital. So the precautionary principle really wasn't an issue there. The precautionary principle doesn't help you in terms of applying the whole suite of IPC arrangements, which, if I'm honest, we're talking about care homes now, and I know there's going to be a future module looking at care homes. We do need to be better at IPC arrangements and training and provision within care homes. That's where our focus should be, and testing is probably one small part of that.
Thank you.
Thank you very much. Mr. Pisani. Oh, you're over there. I'm not sure we're getting you.
Dr. Atherton, I ask questions on behalf of Mind, the mental health charity. The first question is this. At paragraph 269 of your first witness statement, you explain how in July 2020 you advised the First Minister that you remained concerned that the restrictions which were in place were leading to significant negative impacts on mental health and well-being, which were particularly acute for the young. My first question is whether you can help with identifying the information upon which you based that assessment and which gave rise to your concerns.
No, I can't really point to any specific document or technical report or anything. It was really just recognising the difficulties that everybody in society, I suppose there was newspaper reports, all sorts of things. So we were hearing from the public in the same way as everybody was. These were not easy times for anybody. But there's no specific source of information I can point to.
No. Can I seek to assist you by perhaps reminding you of a Mind Cymru report from the month before that, June 2020. It was a survey that found that over a third of young people in Wales had been unable to access the support that they sought during lockdown, and over half of them said that difficulty in getting mental health support had made their mental health worse. Was that something that maybe had figured into your assessment of the state of children and young people's mental health?
Well, I don't remember seeing the report. Of course, as I described earlier, May, June, the river of information was flowing, and it may be something that wasn't brought to my attention or that I missed. But what I would say is that I absolutely recognise the issue that you're describing, because by that time, of course, we'd suspended all non-essential services within the health boards, and mental health services suffered that same setback as people were redeployed to the front line to try to keep people alive. So absolutely there was a downside and a consequence to all of that, and it wasn't just young people, but young people, as I think I said in the report. So I'm grateful to you for bringing it to my attention, because it does, as you rightly say, help me to understand the impact, and we were aware of it, but I don't remember the specific report.
Thank you, Dr. Atherton. My second question is this. Are you able to assist on what immediate steps were taken to address this particularly acute negative impact on the mental health of the young in Wales?
Well, I can't. I can't tell you the specific steps during the pandemic. As we started to emerge from the pandemic, we gradually restarted all of our services, and including mental health services, and it was important that we did that. Of course, for all the services, physical, mental, that there is a backlog of care which we need to deal with, and I am grateful to Mind, not just for the tools that the organisation you represent has been putting into the public domain to try to help to deal with some of that through self-care, through community care, but there's so much more we need to do. So there's a backlog as we come out of the pandemic. Absolutely recognise that.
Thank you, Dr. Atherton. Just one more short topic, which has already been addressed somewhat by Mr. Thomas, and that is inequalities. My specific question to you is on the potential for compound inequalities. We've already seen your concerns about the impact of lockdown on young people in Wales in relation to their mental health. My question is whether children and young people's vulnerabilities to the harms from lockdown, which is a phrase used in a paper you presented in June 2020 for the Executive Directors team, whether that vulnerability to harms from lockdown was compounded by extant inequalities. So, for example, the risk to mental health may have been particularly acute for a child from a racialized community who is living in poverty.
I absolutely agree with everything you're saying, that there is almost a ladder of inequalities, different steps. So if you're from a black minority or a minority ethnic minority group and you're poor, and you're coming from a socioeconomic deprivation in a poorer part of Wales, then your risk of both physical and mental well-being being damaged is much, much greater. And this is why we try, as I've tried to describe, to address this through our approaches to inequalities. But there's no doubt that you're right. There are layers of deprivation, layers of inequality which affect people's mental health. Recognise that, absolutely.
I'm grateful. And just one last question. In relation to that, were there any immediate steps that were taken or, in hindsight, were possible to take to mitigate that inequality? For example, in relation to the issue of digital exclusion, just at the time that many mental health services for children and young people were moving to remote delivery.
Yeah, I think if we look at what happened through the education system, there was a recognition that as education moved to online learning, that people would be excluded. I can't remember the details, but I think there was more provision of information technology support to people who didn't have access to it. It was acutely in our minds, really. And even the sort of support I was, applauding your organisation, the organisation you represent, for providing like CBT and online support for mental health. I recognise that that's not equitably provided if people are digitally excluded. It's something we absolutely need to consider as we try to improve our approaches to equity. Thank you.
Thank you very much. Right, Dr. Atherton, I think that completes the questions we have for you. Hasn't been too long a day for you.
Thank you.
I'm going to say the same as I said to your colleagues. I appreciate the burden that we place upon you in your office when the inquiry asks you to contribute to the inquiry, either by written material or by giving evidence. I'll tell the teams to please not impose upon you again unless we absolutely have to. So if you do get more requests, then I'm afraid it'll be because they consider it inevitable. So thank you very much for your help to date.
Thank you, my lady.
I shall return at 22.
All rise.
Mr. Mills.
My lady, the next piece of evidence comes from our first Spotlight Hospital. For availability reasons, we moved from a day of Welsh evidence to Northern Ireland. With that, may I please call, via the video link, Dr. Catherine McDonnell, who will affirm.
Good afternoon, Dr. McDonnell. Can you see and hear me?
I can indeed.
Okay. If you'd like to repeat after me, I do solemnly, sincerely and truly declare and affirm the evidence I shall give shall be the truth, the whole truth, and nothing but the truth. Thank you.
Dr. McConnell, I'm sorry if we've kept you waiting. I'm afraid we overran a bit this afternoon. Thank you.
Your full name, please.
Dr. Catherine MacDonald, former Medical Director of the Western Health and Social Care Trust, of which Altnagelvin Area Hospital is a part.
And just to give the dates of your tenure, Dr. MacDonald, that was between the 1st of March 2020, I think, and the 23rd of June 2022. Is that right?
Was indeed.
Your witness statement for the transcript is reference INQ 000 477 593. Let us begin, please, with the background to Altnagelvin Hospital. Can you tell us, please, where the hospital is located and describe the demographics of the population it serves?
Okay, so Altnagelvin Area Hospital is located in Derry, Londonderry, which is in the northwest corner of Northern Ireland and abuts the border with the Republic of Ireland. The hospital serves a population of about 180,000, which is a mixed rural and urban population. Demographics, it's got a very small ethnic minority community of about 2%, but it has high levels of social deprivation, with recent statistics telling us that a male in the area will live 6 years less than the average in Northern Ireland, that 22% of people live in poverty as compared to 16% across Northern Ireland, and that it's got the highest level of non-elective inpatient admissions, which is in keeping with what you would expect in terms of high levels of demand on health and social care services.
Did the hospital's position close to the border present unique challenges during the pandemic?
I do believe it did. I suppose I should have mentioned that we do provide some cross-border services, in particular cancer services and emergency cardiac services such as PCI, percutaneous interventions. So, and a large number of our staff live across the border, so we would have a footfall that crosses on daily. And at times during the pandemic, that border was closed. So the Trust was required to provide paperwork to staff to identify themselves as essential travellers, and similarly for patients who were coming across the border to look for services. I suppose I'd also say because there were two different jurisdictions, the guidance and the restrictions often varied. That, particularly in the first surge, was extremely confusing for staff because there was so much rapid change and they were hearing some conflicting messages. And I also believe that we had particularly sometimes not quite in step with the rest of the region in terms of our surges and our spikes, and that might have been to do with some of the differences in terms of lockdown. So if lockdown, we unlocked early, we got a footfall of residents from across the border over to enjoy our restaurants and our pubs, and I think that might have contributed to some of our particular peaks.
Can we move, please, now to staffing capacity? At paragraph 10 of your statement, you say this: Altnagelvin had staffing shortfalls prior to the pandemic, particularly nurses and doctors, creating a high dependency on agency and locum staff. Again, just thinking, please, about the location, did that have an impact on the hospital's ability to fill those shortfalls?
Absolutely. I understand that the inquiry has already heard about the challenges in terms of the region and workforce difficulties. And as is quite commonplace, that when there are shortfalls in a region, they're most extremely felt in the peripheries. So we would have been a peripheral hospital to start with, and that meant that we'd had a long-standing strategy around trying to recruit. Particularly, we had an international work stream, and that had to slow up through the pandemic because of all the difficulties with travel restrictions, with PLAB exams, etc. And that was for both medicine, for doctors and for nurses. It also means that when there are temporary funding for positions, you're very rarely going to get people moving to a peripheral area to move into a temporary post. So some of the COVID funding was temporary, and it was very hard for us, for example, to really to bring additional staff in into our infection prevention control team, into our occupational health team, all sorts of challenges such as that. And I should add that in the Republic of Ireland, the terms and conditions for doctors are much better than they are within the region. So that's also a long-standing and chronic difficulty.
With all of that in mind, were you able to effectively recruit at all during the pandemic?
We used the regional workforce appeal, and through that appeal we got about 500 additional staff. Those staff were less likely to be in the acute front line, but they certainly were very helpful in supporting us in delivering the additional services that COVID required that we set up, such as vaccination clinics, such as testing centres. So we definitely got some benefits from the regional workforce appeal, but it was much more difficult to get highly skilled professional staff such as nurses and doctors.
Next, please, bed capacity. At the start of 2020, can you help us, please, with the ICU bed capacity at the hospital?
The ICU bed capacity was 10 beds in total, which was, and curiously, 7.5 level 3 and 3 level 2. As all organisations, we had surge planning in terms of determining how we were going to increase that capacity and the expectation of a high level of demand. That required us looking at the footprint, looking at getting additional equipment, looking at getting additional staff, and really setting up systems to look at how we would best use that capacity should it be under excess demand. I can give some more detail if you would like as to what we did.
Yes, please. I think it's right, is it not, that the plan was to increase this figure to 24 beds. Can you help us with how this was achieved?
We were highly ambitious, and we had not truly worked out that the constraint was not going to be the number of beds, it was going to be the number of staff that could staff a bed. So I don't think we actually moved beyond 14 to 16. But we did have some innovative ways of trying to take pressure off our ICU in terms of developing high dependency beds within our respiratory units. We expanded the ICU to some extent by expanding and elevating what could be achieved in a respiratory ward by anaesthetists working into that respiratory ward. And the ICU itself was expanded by moving into recovery areas, theatre recovery areas, and additional event spaces being set up by bringing theatre staff and training them up as ICU nurses, and additional anaesthetists joining the ICU team, by the technicians securing additional ventilators and all the additional equipment that was required to provide patient care within those beds. So we gathered all of what is needed, not just beds, in terms of really providing that additional ICU service, and had it well supported in terms of a very collaborative piece of work carried out between respiratory consultants and anaesthetists.
Dr. McDonald, that's very clear. Thank you. Can I ask that you try, if possible, to slow down your answers? We have a stenographer trying to keep up. Can you help us with this, please? How did the length of ICU stays during the pandemic compare to pre-pandemic non-COVID admissions?
The figures which I'm told anecdotally would be that a normal ICU stay would have been about 2 to 3 weeks, but in COVID times, this could have extended for 130 days, at 10 weeks. So the patients that were in the ICU were extremely unwell. So there was none of what might have been described as slightly easier ICU work. It was highly intensive, and patients were there a long time, with the additionality of families not being able to visit in the same way, and the demands on this team to be providing that component of care that families would, and the building of relationships because of that absence. And it was also more challenging because all of the communication with families was being done by phone or by video links. So the psychological and traumatic impact on staff was definitely highly significant.
Can you tell us a little bit about the atmosphere in the ICU at this time, the collective feeling amongst the staff about the standard of care that they felt as if they were able to provide?
The atmosphere changed with surges. In the first surge, there was real challenge because this was a completely new experience for the staff in terms of how they had to work and fill PPE, in terms of trying to manage to have those communications and relationships with patients with the significant mask wearing and all of and changing how they did things. And there was absolute fear. I mean, when we think about the society in general, everyone was terribly anxious about COVID, and we were asking staff to walk into situations where they were actually exposing themselves to it. There was an unfamiliarity with actually wearing PPE, so that there was a real fear of the unknown and a real unfamiliarity that made that first surge just very difficult in terms of the day-to-day work. But as things changed and that bit eased, that stress eased, then it became more difficult because of the chronicity, because of the repeated surges, because of the level of illness, because of the increased frequency of death in ICUs. These patients were very ill, so the number of deaths was much higher. The management of end-of-life care was much more difficult. So it was extremely, and some of these staff weren't ICU staff. They were theatre staff who'd been brought into an area again that they were unfamiliar with. So the whole experience was just high intensity demand on a very chronic basis over a period of 2 years.
At your paragraph 100, you say this: Altnagelvin Hospital faced particular challenges in the fifth surge, which took place over December 2021 to February 2022. It was the second Christmas where the hospital was overwhelmed with admissions of patients with COVID. We often hear that word, overwhelmed. When you use it in that context, can you describe to us what that meant for staff and patients on the ground in the hospital at that time?
When I look back over the 2 years, I think that was the lowest point for the staff group in Altnagelvin Hospital. I suppose we understood that level of concern that staff felt when both nurses and doctors were coming to us as their directors and asking us about where they stood individually, professionally, because of the fact that they felt they were not able to deliver care in the way that they usually would. And I, for example, discussed that with the General Medical Council. My nursing colleague would have discussed that with the NMC because, and that was to do with staff absence. That was to do with the fact that the wards were so poorly staffed, both in terms of nurses and doctors as compared to usual. Because of Omicron, which was highly infective. So it spread like wildfire. If you look at some of the reporting at that time, the numbers of people affected across Northern Ireland was described as extraordinary, up to 1 in 10. 1 in 10 people in some areas, and that would have been our locality. So we had significant losses of staff, and I think some of that was even more difficult because at the time society was getting on with life as normal, and yet within the hospital we were desperately trying to keep that still COVID-free. because we still knew we had really vulnerable patients. We were still trying to keep staff levels at a level that was delivering the best patient care that we could. Staff were getting COVID, so it was the most chaotic moment, I would say, in terms of our particular part of the country.
What problems arose from the dissonance between what people were allowed to do outside and what both patients and staff had to follow in the hospital?
But we were still in full COVID alert in terms of what we expected of staff. So, for example, within the workplace, staff would not be able to all sit in a tea room together. There was still social distancing. There was still limited numbers particularly in a tea room. And yet the same staff, if they were following what was happening outside, could all have gone on a Christmas night out. They could all have gone out to a restaurant or to have a meal together. So we were asking different things of them. There were different things were expected of them in the hospital as compared to what was happening outside. And it was really confusing for visitors who had mask wearing, had stopped, and as soon as into the hospital, there was hand sanitisation, there was mask wearing, there was potentially restrictions to some extent in terms of how many visitors might come. So they found it really confusing as well, and it felt that there were two parallel universes going on at that point in time. There was COVID world, which was work, and then there was non-COVID world, which was outside. And so I think that tension was extremely difficult. And then Omicron just was so infective that it went like wildfire through people groups and through staff and groups. So it meant that we were trying to balance when staff got a COVID or they were in contact with COVID, balancing the risk of bringing them back and then bringing COVID into the hospital, or not bringing them back and having a really fragile workforce that might not be able to deliver the care that we wished. So we were making very difficult risk assessment decisions every day.
Next, please, infection prevention and control. Did the hospital always follow national guidance in respect of IPC measures, or did it at times deviate?
Generally, we followed guidance, but occasionally we applied what I would describe as a little bit of common sense. For example, guidance came through to downgrade some of our PPE just before Omicron struck, and that wasn't to be predicted. So we delayed the implementation of the new guidance until our community transmission rates dropped, and we were content that there was that the potential of transmission within the hospital had eased.
At paragraph 41 of your statement, you say this: the biggest challenge to implementing IPC guidance was concern in the early stages of the pandemic that guidance was developed around supply issues rather than safety, and that safety measures being advised were inadequate. Are you able to provide us with an example to illustrate this point?
I think that when we look back, the IPC protection, or PPE protection, was particularly for people who were in COVID areas, but it wasn't really being prescribed for people who sat outside those COVID areas. So the concern for a lot of nurses and doctors were that with the limited knowledge that there was of how COVID presented, that they too should have had that protection. And thankfully, fairly quickly, that did happen. But there was a sense that normally when you suspect that there might be a risk, that you would use personal protective equipment, and that wasn't possible at the start because of lack of availability. And I would also point out that this wasn't just within health settings. Society at large was concerned for the safety of staff and the working within health. We got multiple donations very generously from people to provide us with PPE. So there was a collective understanding, not just in health facilities, that perhaps there wasn't enough PPE available to protect the staff and their day-to-day work.
Did you ever perceive a difference between national guidance and that issued by the Royal Colleges?
Just the the difference that I've described, that again, the Royal Colleges would at times have suggested that in the absence of knowing whether a patient was COVID positive or negative, that some protection should be in place. But at the same time, they would have encouraged us to follow national guidance. So there's just that tension at the start in terms of who needed PPE and who didn't. But gratefully, we were to see the new guidance come in that allowed us to provide protection for all our staff.
Did that tension lead to a loss of trust and confidence in national directives on the part of your staff?
I think so.
What, if anything, were you able to do to restore that?
I suppose that what we tried to do is to continue to have conversations and to be as open and transparent as possible. I met on a weekly basis. I had an open meeting for all doctors, senior doctors, and there were opportunities to just have conversations to support people in understanding what was possible and what was not possible at points in time.
Next, please, visiting restrictions. It's right, isn't it, that the hospital developed a risk assessment tool to make decisions about whether to allow visits. Can you explain to us how that tool worked in practice? I
suppose I'd start by referring to the first visit. Visiting was very challenging, and we weren't able to offer visiting. But as we started to open up to visiting, the first visit was of a young woman to her husband, the father of her children, in first surge, and we were worried that he was close to end of life, and there was a lot to learn about how to do visiting safely. If we think about that as a scenario, it was really important that this young woman was safe, that she did not contract COVID during the visit. So, it took we set up a system whereby a nurse, for example, met her at the door so that she could walk her through the hospital, through the COVID-safe pathways, to support her in terms of putting on her PPE, about bringing her into a very difficult environment, which ICU always is, but was even more difficult when all the staff were wearing PPE, and to provide her with not just a support around COVID, but just the emotional challenge of that visit, to take her out of that ICU, to make sure she took off her PPE safely, because one of the most critical moments when you're wearing PPE is to make sure you take it off properly, because you're most likely to get infected at that point in time, and to take her safely off the hospital premises. So there was a lot of learning for us in that, about what needed to happen to keep the visitor safe and what sorts of levels of staffing we needed to support someone on a visit. So that's what we gathered. It was through the ethics committee that we sat and we did a template to try and make sure that we could offer visiting equitably within the facility. Because some days it would be easier to do because there would be staff availability, there would be less ill patients, and other times it would be more difficult. So that's what we did.
In your view, did the tool allow the hospital to find the right balance between maintaining a COVID-safe environment and the emotional cost that visiting restrictions could cause?
Yes, absolutely. Absolutely. It was a tremendously supportive tool to staff, and it also was helpful, I think, in terms of conversations with families, because they understood the rationale. It was beginning to understand the risks that had to be managed to allow for safe visiting.
Was the risk, was the tool used to approach the question of visiting in a maternity setting, or did the hospital approach that question slightly differently?
I'm come back to memory now. I can't remember. Apologies, I can't remember.
Do you recall whether in the early stages of the pandemic there was an absence of national guidance on visiting in a maternity setting?
remember our guidance. I remember the local guidance. I remember the regional guidance and visiting to our maternity unit. I can remember that, and it really was that they were only allowed to have a visitor, a partner available, sitting with them through labour. I remember that there was significant restrictions, and I had some discussions with the team in preparation for the inquiry as to how they managed that.
Can you tell us anything about the impact of visiting restrictions in that particular context on patients?
Yes. Maternity was particularly difficult because pregnant women were all highly vulnerable. So we were challenged to balance our duty of care to every woman who came into the hospital to ensure that they were safe. And within the trust, we lost one mother, and it felt like one mother too many. So it was absolutely critically important that we kept them safe, but then being really mindful of the emotional journey of anyone in terms of a baby and the importance of their partner within that. So I know that what happened within the scans where partners did not routinely attend, that there was an arrangement that they would be outside, and if there were any difficulties, that the partner would be invited in to support the mother if there was bad news to be broken. And I understand that the partners were allowed to be with the mothers through labour. And that was our compromise as best we could, recognising the particular vulnerability in pregnant women and for their babies.
You mentioned the Ethics Committee. I think it's right that was established on the 27th of March 2020 with you as its chair.
Yes.
In broad terms, can you help us with what the purpose of that committee was?
If we think back to the 27th of March in 2020, and we had looked towards experiences in Europe as to what we might expect in terms of demand and the pandemic, there was a crushing concern that we would be in a position of needing to ration care, and how that might happen, and some very difficult clinical decisions might have to be made. So we decided to start having those discussions as early as possible. So we opened up our ethics committee. The ethics committee was extremely important in terms of bringing a wide range of people to the table in terms of having discussions. So we had our chaplains, we had lay people, we had academics, we had a non-executive director, and we had obviously some trust staff. And it really was with the purpose of ensuring that we did the right thing and ensuring that we were supporting clinicians on the ground whose anxiety levels were extremely high about this aspect of potential decision making in the future. And it was so that they had a place to bring dilemmas. It was for a place for anyone to bring questions, and it was for us to be in the front foot in terms of developing some tools that might be helpful to them in the moments of crisis.
Some might think that clinicians have to make all sorts of difficult decisions all the time. Can you help us understand how a national decision-making tool about the rationing of care might have helped those working in the hospital?
Clinicians do a lot of what we think in terms of or talk about in terms of difficult decision making in COVID, as you rightly say, is what happens day and daily. But the COVID intensified all of that and asked us to really look at it and added layers of complexity. So it was really important that we dealt with that. I think it felt like an extremely heavy burden for a clinician to carry on their own. And that's why it was really important for us as an organisation to ensure that those clinicians were supported. And we did that by developing some tools and developing an emergency decision support group should they have been in that particular acute position of trying to determine who should receive care. I think it's an area that needs, in peace times, when we talk about peace times, non-COVID, non-pandemic times, it's an area that we really should be doing work on now, rather than waiting until we get into the eye of the storm. And I think that we can never have too much guidance, whether it's regional or national, in terms of helping us to explore these difficult topics and help us and direct us and guide us to do the right thing by each individual patient.
I think it's right that as it transpires, the services of the emergency decision-making support group were never in fact needed.
They weren't needed, but some of the documentation that we developed around it was just really helpful for clinicians when they were working their way through some clinical decision making. But thankfully, it was actually not needed.
Having gone through the process of developing documentation in this area, are there any specific references that you would like this inquiry to consider?
I don't quite understand the question.
In the context of creating a decision-making tool in respect of the rationing of care, having created that at the hospital within the trust, do you have any insight into what worked well?
Sorry, you just froze.
Having created the decision-making tool about the rationing of care, do you have any insight or any recommendations you would like the inquiry to consider about what worked well?
What worked well? I think the security of knowing that there was an emergency decision-making support team being there was critical to free the minds of our clinicians up to look after patients without having that additional worry. We also developed what was called a hospital treatment escalation plan, which was a document which is in keeping with best practice around anticipatory care planning, which had not developed fully in Northern Ireland. There's been more development since COVID. It was developed with reference to best practice and based on a template that had been used in a neighbouring trust. And I think that it was a really important tool as a support to doctors to do the right thing. We want documentation that prompts people to do the right thing, and I think that's what it did. It was a document that we were very, very considered to Ethics Committee to make sure that it was for a single episode of illness. It wasn't a carte blanche, this is what's going to happen to someone, every admission have it single. It was tested out by senior clinicians. It was decisions that came out of it were always referenced through senior clinicians. So there was a lot of very good stuff in that, and was a real support to junior doctors to make sure they were doing best decision making in conjunction with patients and their families in a very complex time. And I think I would definitely recommend that would be available to support all doctors in all hospitals at times like this.
Considering the picture more widely about the support the Trust introduced for staff, can you tell us a little about the measures that were introduced to support their psychological needs?
I suppose my background is psychiatry, so I thought it was extremely important, as did many in the organisation, that we look after, not just protect our staff in terms of infection prevention control, but also be really mindful of the level of stress, anxiety, trauma that they were going to experience within a pandemic. So the first thing that happened, which was critical, was we had 2 senior psychologists who took a lead role in helping to develop a raft of interventions, some of which were linked to the regional initiative of having a psychological helpline, others that were related to team debriefs, crisis interventions, all of which were delivered by the psychologists, plus a wider team pulling on skills from our mental health services. There were already wellbeing programmes in the trust, and they were expanded upon. There's an work stream within mental called Twist West, which was all about really trying to help people just stay well in the middle of the crisis. So there's a lot of work in terms of trying to support staff as they worked in circumstances that were completely unexpected. And that's extremely critical in terms of delivering good patient care. If your staff are well, they will do a good job. If your staff are stressed and anxious, they will not be as available for patients as they would normally like to be. So it was part of our whole approach to patient safety and quality of care.
Finally then, Dr McDonald, are there any lessons and or recommendations that you would like to share with the inquiry based on your experience at Outnagelvin during the pandemic?
I think I'm going to be repetitive and say things that have already been said, but I think the most important one is the workforce and the quality, the baseline from which we launch ourselves into a pandemic. I think that's absolutely critical. And I think the second one is, and it's been talked about, pandemic preparedness. We need the PPE. We need things like the visiting guide. We need some of that those ethical performance that we're speaking about. We need those things in place before another pandemic hits. I think we didn't touch on it, but I think it's really important to understand the impact of the pandemic on elective services in a crisis. The resources are eaten up by the crisis, and the patients not in absolute peril get left behind. So I think there's something about how we think about how we manage elective services. And I think the fourth one I would obviously be passionate about is that we really need to think about our staff, how we look after staff. And, you know, if we look back on those 2 years, and in the midst of all of that, there was no opportunity for staff to rest. Staff did not get an opportunity to rest. It was, we launched from surge to surge, and then we launched into reset and rebuild. And we need to think seriously about how we recruit staff, and then how we retain them, and how we keep them well.
Dr McDonald, thank you. My lady, that's all I ask.
Thank you very much. Mr Wilcock.
Dr McDonald, I represent Northern Ireland COVID Bereaved Families for Justice campaign. And I should say, in the spirit of full disclosure, that Altnagelvin was the hospital I was born at and the only hospital I'm lucky enough to have ever been an inpatient in. But I've been granted permission to ask you questions on two subjects. The first is the hospital's relative success in combating nosocomial infection during the pandemic. And the second is the approach within the Western Trust towards DNA CPR orders. Can I deal with the first first? Can we please have on the screen, and you have it in your tab 7 at page 4, Doctor, INQ 000416-864, page 4, paragraph 2.8. I don't know, Doctor, does this come up on the screen in front of you? Or?
It does, but it's in small writing, so I can't actually read it.
That's not helpful. As I said, if you have your papers, it's in your tab 7 at page 4.
Oh, that's better. 2.6.
2.8 is what I'm going to look at.
Oh, sorry, 2.8. Yeah, appreciate that. I've got it now. Yep.
And this is an extract from a 2021 report that you'll be familiar
with. Yes, I know the
with.
report. Yep, I'm familiar with the report. Yes.
And we can see, can't we, that the hospital was lucky enough to have a 72-ward block opened right at the start of the pandemic. I'm not sure whether it's April or June 2020, but it says June in that document. And that's correct, isn't it?
Yeah, that's correct. Yeah. It actually opened in April, you're correct.
Yeah. What I wanted to ask you was whether you agreed with the conclusions in that paragraph, that undoubtedly contributed to the hospital experiencing what the subgroup described as, at a different part of the report, lower, less frequent, less complex and less sustained rates of nosocomial transmission up until the report was written in May 2021. Do you agree with that proposition?
I do agree that it absolutely contributed. We were fortunate to have a new build that opened up which had single rooms, better ventilation than the older parts of the hospital, and that certainly contributed to the lowered level of nosocomial infections. But I also think, and we had a little bit of a look at this, because we certainly were a bit of an outlier in terms of having less nosocomial infections and less death for those who suffered nosocomial infections. I do think that there were other contributing factors, such as the manner in which we worked through IPC, or Infection Prevention Control Strategy, which was really about making infection prevention control everybody's business. It wasn't just for a small team, it was how we networked and how we got everyone on board and realising it was their business. And the good news might be for you might be that there's a continued decrease, it still continues to be an outlier for other non-COVID hospital-acquired infections. The West continues to be an outlier in terms of performing better, which I think is a combination of many other things, and also IPC, how we think about our IPC practice.
Thank you for that. Can I come on to the IPC practice during the pandemic? Because in your statement, you identified 2 areas on top of the common sense deviations you've told us about, where staff at Alton and Galvin appear to have taken measures to counter nosocomial infection which had not yet been fully reflected in the IPC guidance. And the first one I'm referring to is at paragraph 47 of your statement. You state that staff recognised risk linked to ventilation, quote, in the very early stages, and that this, and again I quote from your statement, was highlighted for them as they repurposed theatre spaces as part of the first ICU surge plan in March 2020. Then the second example where it may be thought that you are identifying areas where staff appear to have gone beyond IPC guidance is at paragraph 50, where you seem to identify that for testing, your trust adopted a practice wider than guidance, and as a result identified COVID positives among staff who would have fallen outside the regional definition for testing. So I suppose, assuming that I'm right and that they were beyond the guidance at the time, is it a matter of concern to you that in order to take the effective steps you've described to reduce nosocomial infection, your trust felt it necessary to take what you thought were common sense steps and steps which could be felt to amount to departures from the IPC guidance?
I think there's always a tension in terms of a pandemic where there's a mixture of approaches, in terms of a command and control approach to guidance, or a guidance that is given and with a permission to have some level of nuance depending on a local intelligence experience and concerns. So I suppose sometimes we took the liberty of expecting that people would forgive us if we made some decisions around what we needed to do, all in the spirit of keeping patients and staff as safe as possible. And I suppose that piece that you refer to in terms of having tested a small cluster of staff in the early days before testing, tracking and trace was all in place, was just the overarching concern that the narrow definition of COVID in the first instance couldn't truly reflect a virus, because no virus would behave so perfectly as to only have 3 potentially presenting symptoms. And it helped to inform us and keep us far from complacent when we were looking at staff and understanding that they could carry COVID and be asymptomatic.
Thank you for that answer, Doctor. Can I turn to my second topic, which is DNA CPR? Because many members of the group I represent have made clear that in their experience, their relatives were, quote, given up on and simply abandoned to their fate. In paragraph 96 of your statement, you describe the development of a trust decision-making tool to provide additional support to decision makers who were working through the pandemic in what you've described as a pervasive climate of fear of scarcity. We're going to hear expert evidence on this topic on Wednesday, but do you think that notwithstanding the guidance that you developed, That pervasive climate of fear and of scarcity resulted in subconscious applications of the clinical thresholds, the guidance expected clinicians to apply to DNA PCR decisions?
I can't talk in generalities, but I can talk about what happened within Altnagelvin Hospital. And what I've talked about in terms of our ethics committee, of me meeting regularly with doctors, was to really try and alleviate anxiety so that people would continue to make good clinical decisions and not move into that space that you're describing where they get so anxious about the future. But I would really want to reassure people about Altnagelvin Area Hospital that there was a really tight senior consultant decision-making group that met every day across every aspect of patients who had COVID, whether they be in older people's service, whether they were in ICU, whether they were in respiratory wards, or whether they were in general medical wards. And they reviewed all those patients as a collective in terms of determining where they placed in the right pathway of care, whether they were improving, whether they were deteriorating, exactly. So it was a very nuanced, within Altnagelvin Hospital, it was very nuanced in terms of making sure that all patients were getting the best care in the right place at the right time. And recognising that was dynamic, that sometimes patients got better, sometimes patients got worse, and that you reframed your expectation in terms of the patient pathway, in terms of the patient's clinical progress. So I can't speak for other hospitals, but I can speak with confidence around how that decision-making happened in Altnagelvin, because of the strong clinical leadership in terms of the consultants who led those services and whom I met on a regular basis, and who brought all those concerns to our ethics group, which met on a weekly basis or twice weekly at the acute stage of the pandemic when required.
Dr. McDonald, we understand your answer. It's very clear. But following on from that, can I just ask you my last question, which is that in paragraph 97 of your report, you point out, in keeping with what you've just said, that DNA CPR was a topic regularly discussed at the Trust Ethics Group, and that to your knowledge, you say there were no issues raised through incident reporting, complaints and raising concerns in relation to changes to practice in applying DNA CPR. I just want to ask you this. Is it possible that the reason you weren't aware, in spite of the efforts you made to find out, of any issues in relation to the application of DNA CPR within the Trust is because the system for complaining about or challenging individuals' DNA CPR issues was not accessible to patients or effective in practice?
Yeah, I appreciate that things could be missed, but I suppose that all complaints. I chaired a group every week that reviewed every single complaint that came through to the hospital, constantly looking for trends that relate to anything. And in particular, we had a group looking specifically at anything relating to COVID. So the group is not just myself. I chair a group with senior professional leads and directors every week, looking at every complaint and looking at every incident that comes through. And it's for that purpose, looking to see is there anything going on that we need to know about. But I'm not saying that perhaps people didn't understand just to use the complaints system to help us know what was going on the ground from on the ground. So I would wish to assure people that we were constantly looking to get feedback to make sure that we were doing the right thing. It was part of our strategy as to how to manage a pandemic.
Dr. McDonald, thank you very much for your answers, my lady. That's all I ask, and I think it's 4:30 exactly.
Perfect timing, Mr. Wilcock. Thank you very much indeed. I think that completes the questioning for the doctor. Dr. McDonald, thank you so much for your help. I'm really grateful, and obviously for all the work that you and your colleagues did during the worst parts of the pandemic. Thank you.
Thank you.
Right, 10 o'clock tomorrow, please.